Okay, so today we're going to talk about a huge subject, non-cardiogenic pulmonary edema. So I try to just focus on some parts of this lecture, especially management of ARDS. So I have no disclosures. So the learning objects are going to talk about types of pulmonary edema, the neurogenic pulmonary edema, high altitude pulmonary edema, tocolytic induced pulmonary edema, negative pressure pulmonary edema. I'm going to talk about definition of ARDS, diagnostic criteria of ARDS with the Berlin criteria. That's the one was in 2012, causes and pathogenesis of ARDS, and the management of ARDS. So as you see here, pulmonary edema classify non-cardiogenic pulmonary edema and cardiogenic pulmonary edema. So our subject today is going to be non-cardiogenic pulmonary edema. So as I mentioned, high altitude tocolytic induced negative pressure pulmonary edema, neurogenic, and ARDS. So we're going to start with negative pressure pulmonary edema. Really not much on literature about it, but what we have is called also post-obstructive pulmonary edema. So usually it's happen if you have any upper airway obstruction, if you have any mass, severe spasm that can cause intense inspiratory effort against a closed airway, and this is going to increase the negative pressure, and this is going to causing more fluid to move to the alveoli and causing acute pulmonary edema. So as I mentioned, causes-wise is infections, a tumor, laryngospasm. Mechanism that's what, as I mentioned, is increase the intrathoracic negative pressure and causing more fluid to move to the alveoli and causing severe pulmonary edema. Management, basically just supportive treatment. You have to treat the underlying cause. So if patient needs to be intubated, you intubate the patient. You can do cricothyroidotomy if is indicated. You can be treated with positive pressure ventilation, and you can use diuresis if needed. And the characteristic of negative pressure usually is resolution is very rapid, and thus you can differentiate it. One of the things that you can differentiate from the other pulmonary edema. Second one, it's tocolytics induced pulmonary edema. It's very rare. It's seen more with obstetric. So what's tocolytics? The medication that used for preterm and preterm labor. So magnesium sulfate, beta agonist, calcium channel blockers. So they found the patients who had the risk of tocolytic induced pulmonary edema if you're using higher dose of this medication, or you combine two medication at the same time, or if the patient's already on steroid. So the mechanism is not well known. Some they said because of the, for example, beta agonists releasing ADH and causing pulmonary edema, and also there is some debate about fluid given with the medication can causing that, but there is no clear mechanism explaining tocolytic induced pulmonary edema. Treatment the same, DC medications, oxygen support, non-invasive pressure ventilation, diuresis, and if patient continue to have forcing respiratory failure, and then you have to terminate the pregnancy. High altitude pulmonary edema, it's a life-threatening pulmonary edema, occurs in climbers and tourists ascending to high altitude, usually above 2,500 meters. Pathogenesis, as you know, whenever you anyone in high altitude, you have low oxygen, and then this is can causing because of the hypoxia causing pulmonary artery vasoconstrictions, and this is going to increasing the pressure in the capillaries, and that's going to causing more fluid to move to the alveoli and causing pulmonary edema. And also there is a sympathetic activity to one of the elements that can causing part of this mechanism for high altitude pulmonary edema. So what's clinical manifestations? So the history very important. Patients. So patients is gonna be has the history that he's in those places. Symptom-wise, there is nothing really specific: shortness of breath, cough, chest tightness, exercise intolerance. Exam-wise, going to be bilateral crackles, wheezing. If severe, you're going to see cyanosis, tachycardia, and tachypnea. And this is because of sympathetic activity. High mortality rate if not diagnosed early and treat, and reaches like 50%. And chest X-ray is going to see like a pulmonary edema. So the management, there is two important things to manage high altitude pulmonary edema. So you have to immediate descent and supplemental oxygen. There is medication that you can use after that if patient's not improving, and the mechanism of those medication causing vasodilatation in the pulmonary artery. So those medication, calcium channel blockers, most commonly the nifedipine and phosphodiesterase inhibitors, sildenafil and tadalafil. There is no rule for diuretics in those patients because of most of those patients already volume depleted. Prevention, so we have to educate them that you have to do gradual ascent, and then it's very important to have a detailed medical history. If patients has previous high altitude pulmonary edema at low altitude or has multiples, and they have to look for underlying causes like pulmonary or cardiovascular, so like COPD, like cardiac shunt. So basically you have to do an echo, PFT. Patients who already have systolic pulmonary hypertension is more than 50 or the mean more than 35 should not have high altitudes greater than 2,500 meters. The neurogenic pulmonary edema is acute pulmonary edema secondary to significant central venous system insult. Patients have like spinal cord injury, intracranial hemorrhage, subdural hemorrhage, meningitis, status epilepticus, and TBI. Those patients at high risk of negative neurogenic pulmonary edema. Pathogenesis is not well known, but one of the explanations they say this autonomic response secondary to increased ICP play important role in the mechanism of neurogenic pulmonary edema. They say that symptom-wise, there is early, it happen minute to hours from the insult, and they or late, 12 to 24 hours after. Shortness of breath, can have fever, tachycardia, elevated blood pressure because of sympathetic. Chest X-ray, the same bilateral infiltration. So important to identify if patient has any CNS insult, and the treatment, you have to treat underlying cause and supportive treatment and avoid excessive diuresis patient because patients already have high ICP. Acute respiratory distress syndrome, ARDS. So the definition of ARDS, is in 1994. We have the previous definition, and then 2012 we have the new criteria, Berlin definitions. So the definition is acute disorder started within 7 days of the event and characterized by bilateral lung infiltrations, severe progressive hypoxemia in the absence of cardiogenic pulmonary edema. So as I mentioned, there is the old definition in 1994 by AECC definition, and then the Berlin definition 2012. So what's the difference? The first one, they didn't specify the duration. The second one, they said within 7 days. X-ray, the same, bilateral infiltrations, non-cardiogenic pulmonary edema. So previously, one of the criteria for the old definition, they have the capillary wedge pressure, which is eliminated in the Berlin definition. And the other thing, different acute lung injury, as defined in the past between 200 and 300. They eliminate that, and now they keep that under ARDS definition. So that's the main difference. Just they remove the acute lung injury and the capillary wedge pressure from the Berlin definition in 2012. Also in Berlin definition, they define the severity of ARDS, mild, as you know, from 200 to 300, moderate between 200 and 300, and the severe less than 100. And just keep in mind with PEEP of 5 or above. So this is the same here. And the incidence of ARDS is 200,000 per year, United States, and mortality reach about 40%. And this is really before the COVID, so it's most likely it's higher now. So this is the Berlin criteria of ARDS, the same that we discuss. And then what the causes of ARDS. So they classify a direct lung injury and indirect lung injury, or intrapulmonary, extrapulmonary classification. So the most common cause of direct lung injury is pneumonia, either viral or bacterial pneumonia, aspiration pneumonia, fat air embolism, toxic inhalation, near drowning, lung contusion. Indirect, like acute pancreatitis, multiple trauma, sepsis, the most common is septic shock, massive transfusion like a trialy, drug toxicity, neurogenic pulmonary edema, and cardiopulmonary bypass. This is the pathogenesis, as Saddam explained yesterday for the sepsis. They used also for the ARDS. So as you see on the left side, this is the normal. So there is no neutrophils inside the alveoli. We have some macrophages there, and you see the surfactant layer, and then endothelial. So whenever you have the insult there, either infections, toxic inhalation, so you start the pathogenesis is here. So you have some destruction in the capillary and endothelium, and then you start to have some migration of the fluid-rich protein and neutrophils in the interstitium here, and then you start to have some fluid collection, and then patient when you start to have hypoxia. Then the hyaline membrane formation, and as I see here, the neutrophils migrate inside the alveoli, and the factors that activate the cascade. You have interleukin 1, you have interleukin 6, 10, tumor necrosis factor, interleukin 8. And also they find interleukin when they activate the fibroblast and causing collagen deposition in pathogenesis. As I see here, so there is a stages of pathogenesis. You have the exudative stage, proliferative stage, and some other classifications. They do the third one, which is the fibrosis. So first 2 to 3 days, you start to have this fluid collection in alveoli and interstitium and causing edema. And then you start to have the hyaline membrane formation, and the peak usually 4 to 5 days, and start to go down. And then as you see, the interstitial inflammation that starts in the second day, and the peak after the first week, and the fibrosis usually started after the 3 weeks. Before we go to the management of ARDS, we have to know what's the ventilator-induced lung injury to prevent that, as the ARDS protective strategy in management. So ventilator-induced lung injury have something called volute trauma, which is epithelial lung injury causing by high lung volume. So high tidal volume can causing volute trauma. How to prevent that? Decreasing tidal volume. Atelectative trauma is the same epithelial lung injury. This is causing by repetitive alveolar collapse from low tidal volume, and this usually prevent by higher PEEP. Barotrauma, like pneumothorax, pneumomediastinum, pulmonary interstitial emphysema, and this is usually caused by high peak pressure. And the last one, oxygen toxicity, causing by free radical damage from high FiO2. That's why usually recommend, or all the time we recommend that patients on mechanical ventilator to keep PO2 between 55 and 80, or the saturation between 88 or above 98, but 92, 93 should be acceptable.
I'm not sure about this trauma about high peak pressure. I don't think it's directly related to that, to high peak pressure. There is other plateau or transpulmonary pressure, maybe it's more accurate than this peak pressure.
Okay.
Just high peak pressure is not directly related to heart trauma. I don't know, is it from some study or from where?
And most of the New England Journal of Medicine, I don't know if this is directly from here, but I can look for it and see.
Yeah, just maybe
Sure.
What's my thoughts?
So management ARDS, treating the underlying cause. For example, if pneumonia, sepsis, you treat with antibiotic, and then lung protective ventilation, prone positioning, neuromuscular blocking agents, ECMO. So ARDS Net. So ARDS Net is a group of researchers among a couple of hospitals. They try to find a safe strategy to treat patients with ARDS. So they did a couple of studies between 1996 and 2003. Unfortunately, most of the study didn't give any good result except one study which was positive, which is published in a New England Journal of Medicine in 2000, which is called ARMA study. And then ARDS Net 2, that started between 2005 and 2012. The same couple of study was done that time, and only one study was showed some positive result, which is a conservative fluid management by decreasing the duration of mechanical ventilator. There is other albuterol nebulizer was called ALTA study, showed no benefit. Omega study, the same, and also give more harm to the patient, so they stopped the study early. And then, so we're going to talk about ARMA studies. A huge study was done in 2000, or published in 2000, New England Journal of Medicine. They using a low tidal volume comparing to traditional tidal volume. And traditional tidal volume, that's the one they use it in the past, 10 to 15 mil per kg. And they try to keep the plateau pressure less than 30 in this study, comparing to less than 50 in the control group. And really they have very good result. Mortality decreases by 20%, and ventilator-free days was decreased too. So this is the result of the study, as you see here on the red, survival. So the mortality rate, as you see here, less than 0.01 decrease, and if you see here the blue, the discharge, also there is some good result about that, and they extubate earlier than the control group. And this is, as I mentioned, that's published in 2000. And this is the same study, just by explaining the plateau pressure more than 30, increasing, I think, is indirect with mortality because of the tidal volume. I think a lot of physicians, they're using this table, PEEP to FIU ratio table. That was done by the ARDS Net group, but just to keep in mind, this was not evidence-based. So this is just expert opinion. So if you start, as you see here, if patients FIU2, for example, 0.3, 30%, you start with 5. If 0.6, you start with 10. So they have two tables, the low PEEP with high FIU2, and the opposite, higher PEEP and low FIU2. I didn't include here the PEEP because Dr. Pandik, I think he explained very well the last time. And there is really no much study. I think the last one was meta-analysis they did, and basically showed only mortality benefit for patients who had ratio of less than 200. They found some mortality benefit of that, and it was, I think, at around 3,000. It was meta-analysis published, I think it was 2009. So this is the Irds Net Protocol. Tidal volume should be ideal body weight. So you have to include the sex and height, use 4 to 6 mil per kg ideal body weight, and you have to keep plateau pressure less than 30. You have to titrate with the respiratory to keep the pH between 7.3 and 7.45. And just keep in mind the goal is not the permissive hypercapnia, but most likely you will get the result of that because of the low tidal volume. Combination of FiO2 and PEEP to keep adequate oxygenation, as we mentioned, PO2 55 to 80 and saturation more than 80. Proning position, so improve oxygenation and mortality. There is a big study called PROSEVA done in published in 2013 and in New England Journal of Medicine. 466 patients with severe RDS with with the PF ratio less than 150 involved in the study. And one of the criteria minimum proning was for 16 hours daily. Mortality in this study decreased by 16% in prone comparing to 32.8 in the supine. There was no difference in complication except high cardiac arrest in the supine group. This is the inclusion criteria that's on in proning. So I know this is just a lecture, not a journal club, but I think you have to know the criteria from the study, so you know whose patients need to be prone and when you have to prone the patients. So they use it, as I mentioned, the ratio less than 150, FiO2 at least 0.6 and PEEP of at least of 5. And the patient that was included was 36 hours post-intubation. 237 was assigned for prone and 229 was in supine as a control group. And as you see here, they have very good mortality benefit, 30 and 90 days. So there is some mechanism why proning improving oxygenation. They say by recruitment of the dorsal lung with a more homogeneous distribution of the ventilation and perfusion. I think the dorsal part of the lung has more perfusion, and that's why when you put patients on proning, they have more chance to ventilate and improving the PF ratio. Also, they find increasing the lung volume, and I think this. So this is important to criteria when to stop proning treatment. So you have patients in proning position for 2 days. What factors you have to depend on to say this patient's should be on supine position, no more proning. So the ratio should be 150 or more, and PEEP should be 10 or less. And FiO2 should be less than 60 or less, and all this criteria should be at least 4 hours and patient on supine position. So patient on proning position, flip him to the supine, and if you have all this criteria, then it's okay to just stop the proning and see how your patient is doing.
That's even after the first day. You don't have to wait for the second day.
Yeah, you don't have to, but you have to have all these parameters before. Yeah.
And I think
the study was done for 2 days.
I think they did not mention when he will be out of window for like proning, like too late.
They said early within 36 hours.
It's preferred. Yeah.
1 week and you not prone him.
You still
try that.
But the benefit of the study was done with 33 hours.
Why would you try that again? If it's 1 week, why would you prone after 1 week?
Because if you go back to the ARDS diagram, the fibrosis has already started, so what benefit are you going to get?
It's a trial, yeah. So
you will not benefit from prone.
Exactly. And the study is just that they did it for this hours, but there is none. I mean, nobody did for 1 week trial for prone position. They did it for this, and exactly.
For example, if you don't have any option, you give it a try and see if he will not respond to proning, you just stop it.
And the fibrosis, by the way, started usually after 3 weeks.
But if you go back to your
diagram,
no,
yeah,
the hyaline membrane, you start the edema, then you start the
but that's the initial.
But it's like day 4 or 5.
No, like it's not, everyone is different, so it's not something that everyone will go with the same time. Every patient has a different, we try the patient after that in room 58. After 3 weeks, he has been on a ventilator and he responded to proning.
And the fibrosis that you said started first week, it started just, if you see the curve, the highest is going to be like 3 weeks and after.
And not all
So that's, you
areas-
still have
Not all,
time.
not all areas of the lung will act
Good
the
point.
same. So even the same patient, they are different. And actually, like this inflammation, this about the question, believe it or not, that they will give you a mortem case that they took the lung and they did pathology. They saw fibrosis, and they will tell you when this patient died. So they will give you time. So that was a question. But it will not be very strict. They will give you like more. So you will know, like once they start talking about fibrosis, you are exceeding the 10 days or 2 weeks
Yes.
time. But in these cases, you just need to try whatever you can.
Okay.
So this is one of some of the contraindications of proning. So hemodynamic instability, increased ICP, multiple injury, massive bleeding, pregnancy, CRRT. They say it's relative contraindication, tracheostomy within 7 days, cardiogenic shock and unstable spine and chest trauma. Another thing, we're going to talk about neuromuscular blocking agents, because we see it a lot of, even in St. Mary nurses, they push, okay, let's start patient on neuromuscular blocking agents. So as you see here, we have two types: depolarizing one, which is working by bind to the cholinergic receptor on the end plate, causing neuromuscular transmission blockage, and the most common drug, acetylcholine, for the intubation, mostly used. And then the non-depolarizing competitively inhibit the acetylcholine receptor on the motor end plate, inhibit end plate potential, and as we have here, rocuronium, cystocuronium, which is the Nimbix, and that's the one was used in most of the study for the neuromuscular blocking agents. So as you know, this is very well-known study, was done published in 2010 in New England Journal of Medicine. Acute is a trial, and that's the study showed mortality benefit for patient start on neuromuscular agents for ARDS. So they evaluate using those drugs in early, moderate to severe ARDS. So with the mostly they use it with the ratio less than 150. It was a good study number-wise. So 340 patients were involved in this study, and as I mentioned, cystocuronium was used as agent for the interventional group. It's important to know whose patients was involved in this. So as I mentioned, moderate to severe ARDS with FiPO2, the ratio is less than 150, and the onset of ARDS within 2 days, and PEEP of 5 or more, tidal volume 6 to 8, idle body weight, and they use, and this is very important in this study, they use a deep sedation really in both arms. So they use deep sedation in the control group, and they use a deep sedation in the interventional group, which is not that the medicine that we practice now. Usually they prefer to do light sedation. So they did deep sedation on both groups, and this is going to make difference in the study that's published in 2019.
They have to use deep sedation for both arms. Because if you're using paralytic in one arm, you have to use deep sedation with it regardless. But in the second arm, it's a placebo. If you use light sedation, it's not blinded anymore.
Yeah, so this was a blinded study.
Yeah, so that's why they have to use deep sedation in both.
Yeah, but it's not going to give you the result of that, because those patients on light sedation, that's what we do now to see if there is any benefit of mortality. And what you do
But
deep...
not for paralyzed.
Yeah, it's not for paralyzed.
Not for paralyzed. Because paralyzed patients usually deep sedate them because it does.
Yeah, we are not debate about that. We debate about the control group.
Yeah, the
That's
control. What
the
he's saying is
control.
that they deep sedated him so that they will blind the study. So, yeah.
Yeah, that's why we'll
when
talk
I
about
walked
the
into
study
the room,
after.
yeah.
That's why the debate was, this study was one of the things that they use in deep sedation. That was the result of the mortality was
And
in
the control group, you mean?
control group. Yeah. The other thing they use it here, PEEP of 5 or more. I think that the last study they used higher PEEP, so here, if you see here, the primary outcome,
They used a different tidal volume too.
it was higher.
Higher.
Yeah, it was higher in this study compared to the last one. So the primary outcome was 90 days mortality. So the initial result of the study was no mortality benefit, but when they did more other factors, including the study and decreasing the FiO2 ratio less than 120, and then they found some mortality benefit 90 days after. And also they found increase the number of ventilator-free days, discharge early from ICU, and a low incidence of paratrauma. And this is the Meyer diagram seen here, NIMBX mortality benefit comparing to the placebo, and was 90 days. So the debate about the study, as I mentioned, they're using deep sedation in both group, and specifically for the control group, and the paralysis that was used in the study was not monitored. 2019, this is a huge study, came and published in 2019 in New England Journal of Medicine, and the patients number, that one was 300 something, this is 1,000 patients enrolled in the study. There is some difference in this study. Tidal volume was less, PEEP was higher in this study, and they did light sedation in the control group.
Which makes it unblinded study.
Yeah, it's unblinded study. Yes.
Yeah.
So the primary endpoint was 90 days mortality benefit, and the same agent was used in this study, and the same for 48 within 48 hours. So this is the comparison between two studies. They use the same agent, same duration, but the difference, the sedation and the higher PEEP, and also the low tidal volume. So the same inclusion criteria comparing to the previous study, moderate to severe RDS with ratio less than 150, but the PEEP is higher here, and the control group received light sedation, or intervention group was deep sedation, and that's non-blind and low tidal volume. If you go deep in the study, the ROSE study, even patients that they included in the first 24 hours, they refused some like 20 patients or 16 patients was on prone position. So this is here mortality. There is no difference, as you see here, in mortality. And really, they didn't complete this study because there was no any benefit outcome, so they couldn't complete it. So the conclusion, as I mentioned, those stopped early because of futility, no reduction in 90 days mortality, no decrease in ventilator-free days, no decrease in incidence of paratrauma, and they find increased risk of cardiac arrhythmia and muscle weakness. So it's the same. This is the difference between both studies. The only thing, if you see the paratrauma, they said in Accuracy study was less and pneumothorax less, but this study was 0.1, which is not significant. And then the cardiovascular event was higher in the ROSE study. So the question is, do we have to use neuroblocker agent in every patient with severe RDS?
Don't use it if severe hypoxemia, we can control that.
Yeah, so most likely yes, so we use it in the asynchrony if patients already on deep sedations, hypoxia, and that's the only thing you can do. And this is what's called breath trial study was done, and they found patients who started neuromuscular agent almost eliminating the breath, stacking the synchrony, and no more lung injury in ARDS patients. So this is the benefit of using neuromuscular agents, no mortality benefit according to the ROSE study, but they improving the asynchrony, decreasing the alveolar damage from effect of the asynchrony, and decreasing the lung inflammation. So the question is, what study do you think is going to go with? Is going to go with the Accuracy study, or you think the ROSE study that was most...
open just for you to decide, but I think they are shifting toward more like as bushes instead of continuous infusion.
Mm-hmm.
So that maybe will give you just more just to decide if you really, your patient like in sedation, continue with like the synchrony, you are not able to do anything with that, you might need to try, instead of the continuous infusion, to go away from this high chance of muscle problems, is to try the bushes. I don't know if there is any study about that, but I think the one that I heard him talking about this other study, they mentioned like going with pushes, maybe it's better, as if you are giving just to get rid of this episode or this synchrony, and see if the just sedation will just help instead of the continuous infusion.
Yeah, because the study was both the study was continuous infusion for. And ECMO, not much really, just the types of ECMO, venous and veno-arterial. Veno-venous, that means the only lung bypass, veno-arterial, lung and the heart, and this is usually for the cardiothoracic surgery when they do the heart surgery. Indications, if patients fail traditional management, including ARDS, net vent management, proning and neuromuscular agents, and refractory hypoxemia if the ratio less than 50 for 3 hours or less than 80 for 6 hours, or persistent hypoxemia less than 100 despite the maximum management. And this is just like summary, the treatment of ARDS with the ratio, what you start with, the mechanical ventilator strategy, and then as you see here, high PEEP, neuromuscular agents, and the ECMO, and the criteria for diagnosis. Okay, so any questions?
Thank you.
Thank you.
Thank you.
Modular access. You can talk now.